Wong from Stanford University
Good
School of
morning.
Medicine.
I'm Dr. Robert
And
Wong from Stanford University School of Medicine, and it's my great privilege to present on AI in Healthcare 2.0 at Yashoda Hospitals, Hitec City, Hyderabad. Today I'll be talking about leveraging AI to improve the MSLD MASH cascade of care. Objectives. First, I will review the epidemiology of MSLD MASH. I will describe to all of you the clinical care cascade and identify where current gaps exist. And then we'll move on and talk about the potential of AI to improve the MSLD MASH cascade of care. This is a summary of steatotic liver disease and the nomenclature definition, and specifically the fact that MSLD and MASH represents a subset of those with steatotic liver disease, also known as fatty liver disease. The focus of today will be on MSLD MASH on the left side of the screen, and we won't be talking about some of these other subsets of steatotic liver disease. I think it's important to understand what the definition and categorization of this disease is before we move on to talk about outcomes. As many of you may be familiar, steatotic liver disease, formerly called fatty liver, in the current nomenclature includes the presence of cardiometabolic criteria, which is seen listed on the right-hand side of the screen. And this really highlights that MSLD is really a metabolic disease. Even though we call it a liver disease, the fact is that it is a true systemic metabolic disease, which brings to the importance of understanding the different metabolic contributors and addressing those health concerns in patients with MSLD. MSLD is a global crisis, as you can see in this study, with global prevalence 30% higher in certain regions, especially as you can see here in South Asia, it is almost 34% prevalence in adults. Particularly in India, MSLD is an escalating crisis that's driven by metabolic dysfunction. It affects roughly 400 million Indian adults and is a major public health issue. The prevalence definitely has hotspots, as high as 70-80% in northern regions of India, and we also see this in pediatric cases as well as non-obese, so you don't necessarily need to be overweight or obese. There's been a doubling of MSLD-related death in India in the past 2 to 3 decades, and as a leading cause of death is actually from cardiovascular disease. And you can see on the figure, while MSLD is a liver disease, it affects multiple organ systems, particularly the kidney, cardiac complications, as well as other metabolic-related condition and organ systems. This slide really highlights the stages of liver disease to understand the progression. Patients develop steatotic liver disease, but over time, with continued injury, can develop inflammation called steatohepatitis, and ultimately develop liver scarring called fibrosis. As patients progress to fibrosis, their risk of developing complications such as decompensated cirrhosis, liver cancer, and liver failure continuing to increase. And hence the importance to identify these patients early, halt disease progression with treatment, and prevent these complications. This slide really emphasizes the relationship with diabetes. Diabetes is a major risk factor, and you can see here in patients with diabetes, the prevalence of MSLD is much higher, with some regions showing up to 80% prevalence of MSLD in those who have concurrent diabetes. Other metabolic comorbidities are also important: obesity, diabetes, cardiovascular disease, hypertension. And this really emphasizes that MSLD is a true metabolic and multi-system disease, and efforts aimed to address this must think about this from a comprehensive metabolic targeted fashion. And this emphasizes again the metabolic contributors of MSLD. In fact, while it's a liver disease, many studies have shown that the leading cause of death is actually cardiovascular. And we know that cardiovascular disease in many world regions, including India, is a leading cause of death. Hence, the public health importance at addressing MSLD and hence reducing the risk of cardiovascular disease-related deaths. This slide again shows the different stages of MSLD, progressing to inflammation or MASH, and different stages of fibrosis, F2, F3, and finally cirrhosis. And this is important to keep in mind because as patients progress through these different stages, their risk of complications increase, and hence there's an urgent need to be able to accurately identify patients at these different stages so that we can implement early effective treatment to prevent disease progression. This study shows that the stage of disease correlates with outcomes, and there's a clear demarcation when patients develop F2 fibrosis that the risk of mortality significantly increases. Hence, F2 fibrosis stage is one of the main targets for diagnostics as well as targeted MASH therapeutics. There are a lot of different tests available to assess MSLD. This is just a summary of some of the different non-invasive tests available. I'm just going to touch on a few of these to highlight where we are and where the gaps are with MASH diagnostics. Fibrosis 4 score or FIB4 score is commonly used. You can see here it's simple, using only 4 variables, but there's a huge indeterminate range. And many studies have shown that this is highly not sensitive and not specific as a standalone test for staging fibrosis. The ELF test, or Enhanced Liver Fibrosis, is a relatively novel proprietary test, and while it has improved the ability to distinguish between different stages of fibrosis, it's still highly limited in accurately identifying those patients with F2+, which is a particular target of therapeutics and current diagnostics. Then we have some imaging modalities. I will just briefly touch on this due to time limitations, but common elastography methods include FibroScan or transient elastography, as well as ultrasound-based elastography methods. These can be effective, but they require in-person visits, and access to these modalities may be variable in different world regions as well as different geographies. And then finally, just to touch on MRI-based modalities, this is perhaps the most accurate of the imaging-based modalities, but this is highly expensive and highly limited in particular world regions. And the utilization of MRI-PDFF and MR elastography remains limited in many world regions. However, it's important again just to emphasize that the stage of disease does correlate with outcomes. Previously, I showed you stage of disease by non-invasive tests, and these are graphs that show that the stage of disease, both the liver stiffness, which measures fibrosis, and the CAP score, which measures steatosis or fat, both correlate well with long-term outcomes. Again, emphasizing the importance to diagnose and stage these patients early so that we can implement appropriate target therapy. This is a summary of the current guidelines from the American Association for the Study of Liver Disease, and it's a stepwise pathway to identify ways to stage and diagnose patients with MASH early. You can see here it's relatively complicated, and the challenge in many world regions, particularly in India, South Asia, East Asia populations, is that the implementation of these are limited, and the non-invasive tests that we have, particularly F4, are highly limited in sensitivity and specificity. Hence, there is a need for novel ways to improve the diagnostic care cascade. The reason for this, again, to emphasize, is we want to treat these patients. And particularly for F2, F3, these are the populations where we want to identify early so that we can plug them into therapy to prevent disease progression. And why is this a crisis? Over 50% of MSLD patients have normal liver tests, which make it difficult to identify these patients with current non-invasive tests. Almost 15% have advanced or significant fibrosis but remain undiagnosed. And as I mentioned, the FIB4 score is limited in sensitivity and specificity, with some studies showing less than 80, maybe less than 70% accuracy for identifying different stages. Hence, we need better ways and modalities to identify these patients. And this leads us to some of the work that we are doing at Carrion Bio. It's a comprehensive AI LLM-based approach where we incorporate non-invasive diagnoses, precision risk prediction, and biomarker discovery. And we leverage existing EHR data, clinical data, to improve the clinical care cascade and link patients appropriately to specialty care and specialty diagnostic imaging. This model that we are developing is a multimodal AI architecture. And you can see here the tiered platform where we incorporate multiple layers of leverage data, including basic anthropometrics, laboratory data, liver function tests, imaging analyses, and we incorporate LLM AI-based modeling. We bring in deep neural networks, and we develop models that are explainable by design and allow not just point-of-care diagnosis, but really allows us to monitor patients longitudinally, understand their disease progression, and then more importantly, to link them to treatment and allow us to assess response to treatments and their improvement in outcomes. One of our priorities is the F2 fibrosis risk engine. I think I explained to you already why this is an important target because of the risk of disease progression, and it is a main target for therapeutics. The model we are developing in its early stage incorporates patient identification. How do we better risk stratify these patients, validate their diagnostic staging, and then ultimately use and leverage this AI LLM-based data for clinical action, referring them to specialty care, getting them plugged into appropriate treatments, and allow them to be continually monitored by their physicians and their healthcare team. The preliminary data that we've already accomplished shows unprecedented accuracy. Our AI-based LM model has already surpassed sensitivity of FIB4 with fibrosis staging. We've also shown very high sensitivity and accuracy for steatosis. So really not just diagnosing fibrosis, but even detecting the early stages of steatosis. And this is projected to have major clinical impact, not only to improve linkage and cascade of care, but reducing unnecessary liver biopsies by more accurately and reproducibly staging these patients and plugging them into effective care. This ultimately will lead to our flagship initiative, which we are building towards, the liver twin. And this allows us to essentially build a twin genotype-phenotype of a patient that allows not just disease identification, monitoring, and therapy response, but allows us really to apply true population health and precision medicine, and may allow us to identify early patients that would benefit from clinical trial enrollments, optimized treatment assessments, and really, from a big picture public health perspective, we really improve lives at a population level. Our liver twin architecture, as you can see here, is multi-tiered and multimodal. We have foundational models that we are building, and the goal is to embed this into existing EHRs. It's not to replace, it is to embed and enhance the clinical care that we provide. And that will enhance the quality of care, as well as the longitudinal monitoring that is so important in patients with chronic diseases. And this will allow us to seamlessly integrate into each health system's existing architecture, whether it's their electronic health records, their laboratory systems, their imaging system. It will allow us to seamlessly integrate this to make care efficient, smooth, and effective. And this is the summary of our multi-modal AI architecture. Not only are we building tools for diagnosis, but ultimately the goal is to improve the MSLD MASH cascade of care by integrating laboratory data, electronic health record data, imaging modalities, and eventually even genomic data. And using this, or we're going to leverage this data to really allow us to build LLM AI explainable models that will improve the cascade of care and really improve the quality of care that we're providing for patients with MASLD MASH. So hopefully I've convinced you in this short presentation that MASLD MASH is a global health crisis leading to both liver and metabolic complications. Therapies are available, but the vast majority of patients are undiagnosed, and this is a missed opportunity for health systems and public health. Leveraging AI has potential to improve the MASLD MASH diagnosis and streamline the clinical care cascade, which will improve patient lives. Thank you.